Good morning, students. Today our topic of discussion is heart block. The other name given for the heart block, it is a conduction system abnormality. We call it as atrioventricular block. It is a kind of arrhythmia. So arrhythmias, as we discussed before, the ECG changes happens. With that we can make out what kind of arrhythmia it is, and this here in this conduction system abnormality also there are a lot of changes happens in the ECG, so it comes under cardiac arrhythmias, that is rhythm and rate abnormality. So if we before we go to the abnormality, we will see what is conduction system of heart. As you all finished your anatomy, you all know that conduction system SA node is the main place where the impulses starts, and if from the SA node it moves on to AV node, and from AV node bundle of His Purkinje fibers, so it moves like this. So if the SA node fails to produce the impulses, the AV node picks up and takes it. So only the difference will be like the rate will be reduced, but the AV node can produce impulses. As we have read, in every cardiac cell has an ability to produce an impulse. So AV node will take up the work if the SA node fails, and if the AV node fails, the bundle of His can pick up and do the function, but the rate will be very less. And Purkinje fibers, and every cardiac cell has an ability to produce impulses. This also a picture shows conduction system of heart. So if you see the normal conduction pathway, SA node, atrial muscle, AV node, bundle of His, left and right bundle branches, and ventricular muscle, and every cell in the ventricular muscle has an ability to produce the impulses. So this is the one which shows about the ECG. P wave is atrial depolarization, QRS complex ventricular depolarization, and T wave represents ventricular repolarization. So before we look into the ECG changes in conduction system, you should know PR interval, QRS complex, and QT interval, so that when you will know the differences. So what is the definition of heart block? It is an abnormal heart rhythm. Most of the time whenever I give test papers, students get confused with the heart block and heart attack. So heart attack is a coronary artery disease where the block happens in the coronary arteries. That is different from heart block. Heart block is nothing but conduction system abnormality where the regular conduction pathway is disturbed and the rate of the heart rhythm of the ECG changes happen. So always remember, heart block and heart attack is completely different. Don't get confused. Heart block is an abnormal heart rhythm where the heartbeats either will be too slow because of poor electrical signals transfer from the SA node to the ventricles. So it is of three types: first degree, second degree, and third degree. We will see one by one. So this is the poem. We will come to this later at the end, so you will remember it. First degree heart block, that is a first degree atrioventricular block. So AV block and heart block are same. First degree atrioventricular block, what happens is the PR interval prolongs. You all know the PR interval is 0.20 seconds, 0.12 to 0.20 seconds. But what happens here, you can see this is P wave and this is QRS. So the P and the Q, there is the space between P and the QRS complex is long. So it means usually it should be 0.12 to 0.20 seconds, and here it goes more than that. So it is more than 4 small blocks. So usually it should not go more than 4 small blocks. That is the difference, 0.12 to to 0.20. So every small block is 0.4 seconds. So if you count, it should not go more than 4 blocks, but here what happens is it is like 1 2 3 4 5 6 7 and almost 8 blocks longer. So if the first degree heart block, the rate will be like 60s, but the PR interval will be long. That is the easy identification of first degree heart block. Following are the common causes of first degree: atrioventricular nodal diseases, like if any of the myocardial infarction affects the AV nodes, of course it happens. Acute myocardial infarction, particularly inferior wall MI. Inferior wall MI causes myocardial infarction in inferior wall causes atrioventricular blocks because it affects the SA node. Myocarditis, inflammation of the myocardium. Electrolyte disturbance happens. Hypokalemia and hypomagnesemia is the common cause. So when patient comes with heart block, you have to rule out what is the cause of this problem. Electrolyte disturbances, drugs sometimes affects the conduction system of the heart. So these are all the main causes. Post myocardial infarction, especially if it affects the inferior wall. Intrinsic atrioventricular disease, where the delay happens because of the conduction system abnormality. Myocarditis, electrolyte imbalance, especially hypokalemia and hypomagnesemia, and drugs may affect the conduction system. So whenever you look into the ECG, first you should see the P wave, you should see the QRS complex, then you should see whether it is regular or not. And in heart block, we will be seeing what is the PR interval, how the PR interval looks. This is very important. So in a first degree heart block, the P wave is normal, the QRS complex is normal. So one P wave followed by a QRS complex. But what happens is the P and the QRS complex, between that it's a very long gap. So we say it is prolonged PR interval. The clinical significance, there is no clinical manifestation, patient may remain stable, and so the treatment is not really necessary. Usually this first degree, when they come up to the hospital with some other problem, they identify this first degree heart block. So otherwise usually they don't show any clinical signs and symptoms, because the heart rate won't drop so much drastically, so they will be maintaining like 70 to 60s, and there is no clinical manifestations and no treatment necessary in first degree heart block if they don't have any clinical symptoms. But you have to monitor them, or you have to tell them to monitor, because it may progress to second degree and third degree heart block. The next one is second degree heart block. Second degree heart block is of two types. We say it as Mobitz type 1 and type 2. So Mobitz type 1 is otherwise called Wenckebach heart block. So first degree and second degree heart block. Second degree is again classified into Mobitz type 1 and type 2. Wenckebach is the other name given for Mobitz type 1. We will see how it looks. Mobitz type 1 Wenckebach, conduction through the AV node progressively delayed. So until a drop beat is seen. I will show you in the ECG. Second degree heart block is characterized by disturbance, delay, interruption of atrial impulse conducting through AV node to the ventricles. It is the same. From the SA node to AV node, the impulse is fine, but from the AV node to the ventricles, it is delayed. Causes, of course, as we said, drugs, hyperkalemia, hypothyroidism, inferior wall myocardial infarction, as it happens, affects the AV and SA node, cardiomyopathy, rheumatic fever, myocarditis. So most of the causes in heart blocks are same. So type 1 Wenckebach, PR interval prolongs with each beat until a dropped beat is seen. So we have seen, whenever you look into an ECG, there is a P wave followed by a QRS complex. There is a P wave followed by a QRS complex. But what happens to the PR interval? This is a normal PR interval. And what happens the next beat? This PR interval is prolonged. It is again too much prolonged until a dropped beat. Here there is a missing of a beat. So the PR interval delays or progressively delays until a dropped beat is seen. So second degree heart block, Mobitz type 1 or Wenke back. Why we say it as Wenke back is the PR interval progressively prolonged until a dropped beat is seen. So here there is a missing beat. So again there will be a normal PR interval. So this is how it goes. PR interval, first it will be normal, next it will be little longer, and the third one it will be more longer until a dropped beat is seen. Again it will become normal. So if this progressively prolonged PR interval until a dropped beat, we say it as type 1 second degree heart block or Wenke back second degree heart block. Clinical, there will be mild symptoms because it's second degree and there is a dropped beat, so automatically it affects the heart rate. So patient will have lethargy, confusion, some kind of mild symptoms. So if you see patients comes up with the symptoms, of course pacemaker is the only option. So for conduction system abnormality, there is nothing can be done, only pacemaker is the main option of treatment. So if patient comes with clinical symptoms in the day, automatically we think of putting them in pacemaker. If this second degree heart block happens only in the night, then there is no treatment needed, but you should check whether they progress to third degree heart block or not. Next one is Mobitz second degree heart block type 2. So in type 2 what happens? Conduction through the AV node is constant. PR interval is normal and constant. Occasionally a drop beat is in. So this is better than the first type 1 because the AV node conduction is normal and in between there is some dropped beats. PR interval is normal. So here you can see there is no problem with the PR interval. First degree heart block prolonged PR interval but regular. Second degree Mobitz type 1, there will be a progressively prolonged interval, PR interval until a dropped beat. Here what happens, the PR intervals all are normal, but only there is a missing of one drop, one beat. So this is Mobitz type 2. So Mobitz type 1, as we said, progressive PR interval until a drop beat seen. In second degree, drop beat or missing of beats happens, whether it is type 1 or type 2. But in type 1, Wenke back, PR interval is progressively prolonged until a drop beat is seen, whereas type 2, PR intervals are normal, but in between there is dropped beat or missing beats are seen. Clinical symptom, this is more significant disease, of course, because drop in beat second degrees are sometimes considered as significant. Pacemaker is the treatment, and you have to monitor this. Patients may progress to third degree heart block. Next we will move on to third degree heart block. It complete failure of the AV node. The AV node will not pass equally the impulses to the ventricle bundles. No impulses from SA node will pass through to the ventricles. So AV node blocks the SA node's impulses. Some part if the conducting system will take over as pacemaker of the heart. So what happens if SA node and AV node fails? What happens? Every myocardial cell can take it its own way to conduct the heart impulses. So this is what mentioned here. Even a myocardial cell can produce 10 to 15 beats per minute. So what happens? The rate will be like that. So third degree AV block, also referred to as third degree heart block or complete heart block. Here disorder of the cardiac conduction system when there is no conduction through the atrioventricular node. So the SA node impulses never pass through AV nodes, atrioventricular nodes. Third degree heart block is otherwise called complete heart block. P wave rate normal, ventricular rate slow, ventricular complex may be broad, idioventricular. So you can see the QRS complex will be broad. The P wave will be having, for example, the atrium will be functioning in its own way and the ventricles will be functioning in its own way. There is no coordination between P and the QRS complex because SA node is giving impulses to the atria, but it is not passing through the AV node. So what happens? Ventricles are not getting the impulses, so automatically ventricles will start triggering their own impulses. So there won't be any match of P wave and QRS complex. This is what happens here. See, the third degree heart block is a complete heart block because you can see the rate drops below 40. Here the P wave has taken the impulse but no QRS. Here there is a QRS but there is no P wave. Here there is no QRS. Here there is no QRS. Again finally the ventricle started triggering here. So what happens? There are a lot of P but very few QRS. It means the SA node is producing impulse but the ventricles are not receiving it. So ventricles will start producing their own impulses. So here the clinical symptoms are very high. Patient will have loss of consciousness, fainting attack, low BP, confusion, everything. Can lead to standstill or VTAC or VF. So patient may go to ventricular rhythms like ventricular tachycardia or ventricular fibrillation may end up in cardiac arrest. So what is the treatment? Here you have to put them on a permanent pacemaker. Clear? So this is very important. Now we will move on to the poem here, what is mentioned. This is a heart block poem. It says, if the R is far from P, then you have a first degree heart block. So regular PR interval prolonged, we say it as first degree heart block. Longer drop. So PR interval when it starts normal, longer, more longer, and again there is a drop beat, then we say it as Wenke back or Mobitz type 1. If some P's don't get through, then you have Mobitz type 2. If there are some P's where there is no QRS complex, it means dropped beats, then you say it as Mobitz type 2. P's and Q's don't agree, then you have a third degree. So there is no matching of P and QRS. So P is in its own way and QRS complex in its own way. The atria is getting the signal in a different way and the ventricles are producing the signal in a different way. We say it as third degree heart block. So first degree prolonged QR interval, second degree Wenke back PR interval, progressively prolonged until a dropped beat is seen. Mobitz type 2, there will be a missing of beats in between which needs pacemaker. Third degree, it is complete heart block where the P and QRS has its own rhythm. There is no regularity or proportions are not matching at all. See, instead of for 5P, there is only 2 QRS complex. The symptoms will be severe and patient needs pacemaker. Next we will move on to nursing management. Assess the high risk patients. This is very important. You should identify what type of block it is. It is first degree, second degree or third degree, and you see patient has clinical signs and symptoms and see who are all in the category of high risk. Monitor ECG. This is must. So you should put them on cardiac monitor and monitor the ECG. Assess the family history of any heart disease, history of smoking and alcoholism, monitor lab values and serum cholesterols, especially electrolytes you have to monitor. Just check whether patient has any coronary artery disease or previously had a myocardial infarctions. Monitor vital signs. Instruct to avoid high fat and oil rich food, of course, cardiac lifestyle modifications. Hope you understood. So here the clinical manifestations, first degree there is no, and second degree Winky back there won't be much but slight symptoms. Mobitz type 2, of course, they may come up with some confusion and fainting attacks, and in third degree they will have a rate drop of less than 40. For example, SA node is having a ability to trigger more than 60. AV node has a ability to trigger more than 40, not more than 40. So if the AV node and SA node fails, the bundle of cells and Purkinje fibers can produce impulses, but it will be less than 40. So the third degree heart block, the rate of the heartbeat will be like 40, less than 40 per beats per minute, which may affect and causes clinical manifestations. Hope you understood. Go through the PowerPoint and answer my questions. Thank you.